So, coming to the first, is the basic study design valid for a randomized control trial? So, before that, little background about why the study was done. So, for large vessel ischemic stroke within the window period, the original management trial 2014-15 was just thrombolysis alone. Then, after the development of endovascular intervention, the management of choice became thrombolysis plus endovascular intervention. But this study, actually, we have never had a study to demonstrate whether endovascular intervention alone versus thrombolysis plus endovascular is superior. So the first two arms have been studied extensively and the standard of care was shifted to the middle arm, but the middle and lower arm have never been studied head to head in the trial. So actually this is what, so the standard of care now based on these 5 large multi-center trials done in 2014 and the Hermes meta-analysis of these trials showed that it was significantly better to have thrombolysis plus endovascular intervention in patients who are amenable for both. However, what these authors of the current study have shown is in direct safe and DUVT and 6 of these trials since 2018, none of them had established actually superiority of EVT alone versus EVT plus thrombolysis. And all the trials, except for 2.2% of the patients, received tenecteplase, which was an older generation of TPA. We are now looking at all. They received alteplase. We are now looking at tenecteplase to see if it's superior to these trials. So, did the study address a clearly formulated research?
You want to show the first slide? The
Yes.
people know which study it was.
Was
that your first slide?
Yes, sir.
So, this is the study.
Yes. So now the question is one, whether in a head-to-head trial, whether tenecteplase with endovascular intervention versus pure endovascular intervention, which is superior.
So this is from any jail?
Any jail. So published in 2025.
And from? Where was it done?
From China. Okay. So did the study address a clearly formulated research question to determine whether intravenous tenecteplase plus endovascular thrombectomy would lead to a higher likelihood of functional independence at 90 days based on the MRS than pure endovascular thrombectomy alone among patients with stroke due to large vessel occlusion. So the PICO statement, the population was patients who were more than 18 who present within the window period with a large vessel stroke. And the intervention was a bolus dose of tenecteplase and endovascular intervention compared to a control where only endovascular intervention was done. And the outcomes they studied, the primary outcome was functional independence, described as a score of 0 to 2 on the modified Rankin scale. The time period of follow-up was 90 days for these patients. So this was the overall PICO of the study. So coming to the inclusion criteria, they included all adults who presented within window period with no significant pre-stroke functional disability. That was their criteria. With the large vessel occlusion. One of the inclusion criteria, however, was that EVT was planned by the clinical care team. They did not specify based on what, they just said based on Chinese stroke guidelines. So there could have been a possibility that it was not planned by the clinical care team, but that is not clearly. And of course, with informed consent. Coming to the exclusion criteria, of course, if there's any hemorrhage, it is excluded, intravenous thrombolytics, or any allergic response, known pregnancy, or if there any contraindication to radiographic contrast agents, or if they're currently participating in any other trial. The other main limitations were due to the procedure itself, such as arterial tortuosity or a pre-existing neurological or psychiatric disease that would prevent the assessment. And terminal disease with life expectancy lower than 1 year. One thing is that they've also mentioned if they were unlikely to be available for follow-up in 90 days, they were to be excluded. Again, they have not excluded, they've not mentioned that they've excluded any patient based on this, but we're not aware of how many were excluded from this. So just to recap, the modified Rankin scale is basically a disability scale that is used to quantify the disability as an outcome in this study. So 0 is no symptoms. The higher the score, the greater the disability. So the lower score is what is desirable, and that's what we're trying to study. 1 is no significant disability is independent. 2 is slight disability, still independent for ADL. 3 is moderate, requires some help, but unable to walk without assistance. 4 is moderate to severe. 5 is severe disability, and 6 is death. So this was the score that was used.
What was their good outcome? 0, 1, and 2, or 0,
0, 1, and 2 was considered.
That's important because some trials.
Yes.
For the statisticians, we have this is ranked data. So qualitative data which is ranked, ordinal data. Some people take 0, 1, and 2 as good outcome, 3, 4, 5, and 6 as bad. Other studies will take 0, 1, 2, 3 as good outcome. So what have they taken?
They've taken out.
You should be careful when you do meta-analysis. The same outcome looks very MRS good, bad. But you should be careful that all studies to 0, 1 and 2 only as good, everything else as bad. Because it changed substantially if you take 1, 2 and 3 and then ordinal data you break it as a dichotomous outcome. To be careful of that. Okay.
So was the assignment of participants to the interventions randomized? Yes. It was a web-based randomization. Was it sufficient to eliminate? Yes. It was a fixed block randomization scheme with block size of 4, but the randomizing codes were actually hidden. And was the allocation conceived? Yes, it was. So were all participants who entered accounted for at the end of the study? Were loss to follow up and exclusions after randomization accounted for? Yes. In the next slide, we have the concept diagram. For participants analyzed in the study groups to which they were randomized, intention to treat analysis was done. Was the study stopped early? No, it was not stopped. So coming to the concept diagram, actually 554 were randomized, but they did not mention how many were screened. That even the supplementary we were not given how many were screened. Of this, 279 were allocated to the intervention arm and 275 to the control arm. Now, actually, we go all the way down to the bottom. 278 were included in the intention to treat. So, intention to treat was done, except for the one which withdrew consent. But they could have included that patient if they had the baseline data. Apart from that, the other thing on this slide was that they have data for 278 patients. They have not lost a single loss to follow up. And similarly, even on the control arm, they have the data for all patients, how many died, and every one of them were accounted for, which may be a little difficult to achieve in all settings. So this was the this. So coming to the study design appraisal itself, it was a clearly formulated research question. Randomization was adequate, allocation concealment was done, and completeness of data is available. So was the study methodologically sound? So were the participants blind to the intervention? It's an open label trial, and the reasoning was that the manufacturer said they were unable to provide a placebo for 10 days. So both the patients and the treating doctors were also, it's an open label trial. They were aware of the intervention. Were the investigators blind? The clinical staff were also informed of the treatment assessments after randomization. So the outcome assessors, however, were blinded. Because two independently trained neurologists who are certified in using the modified ranking score, who are doing the independent assessment. They also had a secondary outcome of radiological outcomes, which was again done by an independent laboratory in a blinded manner. So both the outcome assessors were blinded, but both the participants and the investigators were not blinded in the study. It was openly. Coming to the baseline characteristics, whether the groups were similar at the start of the study. So by and large, the age and the gender and the pre-stroke ranking scale were similar in both groups. However, the site of occlusion showed a significant difference in the internal carotid artery versus the vertebro-based lab. So whether it's a posterior or anterior circulation was a significant difference between the two groups. So if you see 77, it's 27% and 32% in the other arm. Similarly, posterior circulation in the intervention arm was 10% and in the control arm was 7%. Similarly, the median time from thrombectomy puncture to reperfusion was also different in both the arms. So the first two outcomes they could not apply because the time to begin the thrombolysis could not be applied. The other arm did not receive thrombolysis. But from thrombectomy to reperfusion was definitely compared in both arms and both were different. So these were some differences in the baseline characteristics.
One arm? Oh, okay. So do you think that 9-minute difference in thrombectomy to perfusion would have made a difference to the final outcome?
So in the studies that I looked up on the brain, 3 minutes is the average time that the brain tissue can remain hypoxic without.
So that 9 minutes is significant.
It's probably
in favor of
the intervention arm, so because that was 9 minutes less in the intervention.
So 9 minutes in favor of thrombectomy plus
tenectomy.
But their hypothesis was that thrombectomy alone will be enough, no?
No, sir. Their hypothesis was that this is superior to endovascular alone.
So this favors their hypothesis.
Yes.
What about more internal carotid is good or less internal carotid is good?
So this is something that was a little difficult. Actually, the posterior circulation strokes are more challenging to do the thrombectomy process.
So in that way, there are more vertebral artery strokes in the combination arms.
Yes.
So in that sense, they are slightly worse off.
Yes.
Okay. Did they give a p-value?
They have not given a p-value.
Actually, that's one good learning point. We should never put a p-value for baseline characters. P-value is only for hypothesis testing. We are not testing the hypothesis that baseline is different. This is a clinical judgment. That's why I asked. You have to make up your mind whether that 27.7 and 32 is so much different that the study is meaningless. Suppose you're worried, what can you do?
You do a worst case, or we can match for the.
Statistical regression analysis to adjust. At the end of it, you'll get a hazard ratio or relative risk. You have to adjust for these baseline differences. Adjust the analysis. Okay.
And some of the other baseline characteristics that we got from the supplementary. So again, there was a difference in the intracranial versus the extracranial occlusion. We would expect that the extracranial will be more severe because the occlusion is more proximal. So there was a significant difference there. And in the medical history also, hypertension and hyperdyslipidemia also, there seem to be 4 to 5% difference in both the arms, which are significant risk factors for.
So, do you think that these differences in baseline and randomized, the randomized baseline characteristics should be equal? Is it because they did a poor randomization?
So the randomization technique that they've described is adequate, sir.
So why? Then how do you explain this? We have to give an explanation.
Maybe the sample size should have been.
Yeah, that's right. We can't ask them to do a bigger sample size. With 278, these are things which happen by chance. If you have 20 variables by chance, one will come different, appear different. So we should not say that. So these may be just chance findings, and some variables suggest one arm is have a worse prognosis, and the other variables for the other arm. So it's overall seems to be somewhat balanced.
And
otherwise, you have to adjust for 20 different baseline variables. You say every if everything was if that hypertension was 61.5, 61.5, that also would make you a bit worried. Hey, how did we get by magic? So I wouldn't say that anything is terribly different. They are different. Like cholesterol is 24/19, whereas the other one, hypertension, is more this side and this. So overall, I'd say yeah, there were baseline differences, but they're not that terrible that the study should be discarded and said it's. If the randomization is poor, you won't even look at the results because that is the part of a study. You say, yeah, there were some issues, we are a little concerned. Maybe it's because the sampling was small. Okay, go on.
So was a power calculation undertaking? What outcomes measured were they clearly specified? So they actually assumed that this is based on previous pool data. They assumed that in the thrombectomy alone group would be 41%, and in the combination arm would be 54%. So that was the difference they were looking for 13%. And based on that, they calculated sample size 231 patients per cohort, with 462 total patients with an 80% power and two-sided alpha of 0.05. So they increased the sample size to 272 to account for a 15% attrition. So 14% was, 13% was the difference that they were expecting to measure. So coming to, apart from the experimental intervention, did they receive the same level of care? So was there a clearly defined study protocol? Yes. They said that it was based on the Chinese stroke guidelines that both arms were managed apart from the intervention.
Did they give a protocol number?
I will check it.
For NEJM articles, there will be a protocol number. So for all of you published, they should be okay.
If any additional intervention was given, no additional intervention was given. They were very clearly documented that nothing. And the follow-up intervals were the same for both groups at 90 days. So coming to the methodology, participant blinding was not present. Investigators were not blinded. Outcome assessors were blinded. The baseline characteristics, some are similar and some are significantly different. And the standard of care was followed in both arms.
So the question to ask, the investigator blinding not being there, could it have affected the outcome?
Yes, sir. It could have, in the sense that if they could also the block size of 4, they could have predicted whether.
No. Here you know, no.
Yes.
Not blinding means I know who got thrombectomy and thrombolysis. I know who got thrombolysis alone, or thrombectomy alone. How could it have affected the study? So, in theory, if I know that you got thrombectomy and thrombolysis, let's say, oh, you got good care. Oh, this poor chap got thrombectomy alone. Let me give extra physio. Let me ask him to come back regularly. Nobody will document that I did all these co-interventions. But it is possible that that's why it's a little bit of a red flag. But so that's the whole worry that there were some co-interventions. But usually people will not document that I did X and Y. So that's the thing. Outcome assessor blinding is very good because then otherwise the outcome assessor is subtly put 2 as 3 and 1 as 2. Those things possible. Okay. Baseline characteristics, yeah, they were different. So now we must stop at this point and say, is the study so bad that we have to stop?
No, sir.
Is that it was got some issues on baseline characteristics? Could they have done blinding of the intervenants?
It was possible. With the placebo, it was possible.
When we have tried in our hospital, very expensive. Go to a pharmacy company, you produce a another wire which looks just like the nectar place and it should look same color. Nobody should be able to make out the difference. That's quite a costly enterprise to do that. That is the only issue there. Okay.
So what are the results? This is just a summary slide of the results. We're going to in detail. So from their primary outcome, what they found was the functional independence 52.9 and 44.1. So it fell short of what they were trying to find. That 14% difference they didn't achieve. But the p-value came significant.
How much did they achieve? 9?
Yes, sir. It's 53 and 44. So it's around like 8.8. And the safety outcomes were again that they didn't find a significant difference between the two in terms of hemorrhage and mortality. Those are the two.
Remember, the study is never powered for safety. So you must look at signals. Like, is it which is worse, bleeding wise?
The both arm is worse, as in tenecteplase plus thrombectomy is more than just thrombectomy alone.
So that's the, it will be worried. Hey, there's slightly more bleeding in that arm.
Yes.
It does better overall. What about death?
Death is also more in the arm with the interventions.
So how do you interpret death and the functional independence together? You're more likely to die, but you're more likely to be independent. How can you be independent after death? Is that response clear?
Both.
So what will happen is the people with the dual arm, thrombectomy plus thrombolysis, will die early. Those who survive will survive much better than those who didn't survive with the other arm, those survive with the other arm. So when you tell a patient that when you're going to do tenecteplase thrombectomy, there's an initial mortality which is slightly higher. But subsequently, if you survive that, you're likely to do much better. Functionally, you do much better than the other group. So that's a. So the other thing is that if you say higher intracranial hemorrhage, and if you have gone and done a procedure, who has to operate the patient and evacuate the blood clot in the brain if you have a hemorrhage? There's a medicine consultant, if you order thrombolytic, and the patient has an intracranial bleed and is severe, we have to make sure neurosurgeon is at hand to evacuate the bleed because we cause the bleed. So that's the other thing. When we have tenecteplase plus thrombectomy and you say higher amount of hemorrhage, then we have to back up that hemorrhage part.
So coming to the results, were the outcomes measured and were they clearly specified? Yes, they did mention it. How are the results expressed? That is coming in the next table. For binary outcomes, were relative and absolute effects reported? Yes. Were there results reported from each outcome for at the follow-up interval? Yes. Was there any missing or incomplete data? No, they are accounted for every patient. Was there a differential dropout rate? No, no significant dropout rate. Were any potential source of bias identified from our appraising so far? Nothing significant. So they used actually the generalized odds ratio and the win ratio approach. I just wanted to highlight a little bit about the win ratio approach. So when we actually use the win ratio approach is when there is a hierarchical series of variables that you're trying to assess. For example, like mortality versus hemorrhage. And mortality is definitely higher. Now, the problem is when you traditionally look at any outcome, whatever is the first event to occur, that is considered the outcome. And the patient is removed from the rest of the analysis. So, for example, suppose they had a hemorrhage, they're immediately counted as an outcome is over and they're not counted for the mortality, which may be a far more significant event. So we use something called, we pair every single outcome for these two arms and we look at how many events have occurred and that is considered a win versus when the event didn't occur, it's considered a loss. So by adding up all these pairs, we can actually create a hierarchical analysis of this, that just because one event happened, that patient is not removed from the pool, but we go ahead and look at which are the more significant events and even more weightage than just one event. And based on that, so for just one outcome, it's easy to look at. One hard outcome, it's easy to just look at the odds ratio. When we look at multiple outcomes where we need a hierarchical thing, we need to look at the win ratio together and whether p-values report. So if we actually see the outcomes, the primary efficacy outcome they've given as a risk ratio. So the modified Rankin score of 0 to 2 at 90 days was what they looked at as a primary outcome. Here they found that 52.9 and 44.1 were the two arms that they looked at. With an unadjusted p-value, unadjusted value of 1.2 with a p-value of 0.04. So actually the confidence interval there is entirely on the other side of 1. It's not crossing 1. So they did get it as significant. This is despite not achieving the measurement that they were looking. They were looking for a 14% difference. They didn't achieve that. But that's probably because the attrition was so low that the sample size reached higher than it was originally intended to be. And if you look at the other secondary outcomes, the only one where it was not, where it fully crossed one, apart from that, in the secondary outcomes was successful reperfusion and initial angiogram prior to thrombectomy. So just by giving tenecteplase, the patient got reperfused. And that, although it's not powered for that, that alone came as the confidence intervals are all on the other side of 1. So which is possible because the tenecteplase might have reperfused the patient. Coming down to the safety outcomes, which are the other important things we were looking at. The difference between the two, again, all the confidence intervals were crossing 1 there also. And it was looking, they reported it as hazard ratios with the 22 and 90.9. So the main things they looked at was mortality and symptomatic intracranial hemorrhage, either clinical, that's symptomatic, or radiological hemorrhage at 48 hours. So overall, looking at these outcomes, comparing the safety outcomes and the primary efficacy outcome, the study is pointing that thrombectomy plus tenecteplase is a viable solution for these patients over just thrombectomy alone. So we did a best and worst case analysis. This is actually using a Pedro CI tool using the confidence intervals. So we actually see there were 147 patients in this arm and 1 lost to follow-up. So in the best case analysis, we actually put 148 patients in this arm with 279. And the other arm, which was 120 patients, there were actually 3 lost to follow-up. So we kept the event rate there at 120 and added 275 to the denominator. And so with that, we actually got an absolute risk reduction of minus 0.909 with a confidence interval there. And the odds ratio was again 1.4 in this dose. Similarly, we did a worst case analysis in the same subset. Here we entered 123 here. 3 additional patients were added to the events in the control arm. And we added the same number in the intervention arm. We just added it to the denominator, 279. And in the worst case scenario, where all the patients in the control arm did well and the event rate happened in the control arm and not in the intervention arm, we got a relative risk of 1.17 there. So looking at these two also, it looks like it is favorable.
Go back. Go to your best case scenario.
Yes, sir.
Let's ask the statisticians. Odds ratio 1.45 or relative risk 1.21. 1.02 to 1.44. Is that significant? Why? It doesn't include 1. If your odds of death and your odds of death are same, then the ratio is 1. But here the ratio does not include 1. So in the best case scenario, it appears that best case means all those people who are not there or were there, you add them everything in the denominator. But the outcome, they don't die. You assume that they didn't have a bad outcome. Go to your worst case scenario. Now can you interpret the relative risk? 1.17 means one group has 17% more. What is the confidence interval? 0.99 means one group has less risk. Other group 1.39 means one group has higher risk. Interpret the odds ratio. 1.37, one group has got a 37% higher odds of death or bad outcome. What does 0.98 mean? You can see where's 0.98. The bottom of the slide, 0.98. What does that mean? It's possible that one group has better outcome. What does 1.9 mean? It is possible that the same group has a worse outcome. How can a drug have good outcome and bad outcome? So how is the interpretation of this analysis? Would you take 1.37 as the odds ratio and just keep it as that? Or what would you tell the reader? Not significant means there is no difference. So when you do the worst case analysis, suddenly it appears that there is no difference. So here you must be a bit cautious when you interpret the study. Hey, even though the loss to follow-up is only 1 and 3, very small numbers. In the study of 257 patients, there was only 1, not even lost to follow-up, he withdrew. The other group only 3 withdrew. Everybody will say, oh, that is very small. Let us not consider that. But when you do the slight worst case scenario, the results. So many people will calculate what is called fragility index. So statisticians, you can calculate that. Just by adding 1 and minusing 1, suddenly the results change. Yeah, the results show the study drug is very good, but the results are very fragile. Even a small change, like one person becomes dead in this group or one becomes alive in that group, suddenly the results change. So the results are a bit fragile. So here I would say we interpret the results with slight caution because the odds ratio suddenly becomes non-significant when you just add 3. Okay, go on.
So will the results help locally is the answer. So are they similar to the patients in answer? Yes. Actually, the diabetes prevalence that they reported in the study of about 20%. That's very close to Indian diabetes. Hypertension prevalence is similar. We are similar genetically to the Chinese. So would there be any differences in our population and theirs that alter the outcomes in the study? No significant differences we could identify. They've almost accounted for everything.
That we should go back to your baseline.
Yes, the baseline is similar to.
Okay, so some of the things you said in baseline are that there's diabetes.
That's in the next.
So you said that diabetes, they have 20%, we have 20%, some of us stroke 70. Just go back to your previous slide. The time to thrombectomy, they have put, where's the first one? Time to randomization is how much?
Time to randomization is 6.
No, time from last known to randomization is 159. That means 159 is how many hours?
2 or less than.
So within 2 hours of feeling completely well, you have come to the hospital, consent is taken, your diagnosed stroke, consent is taken, and you have been randomized to 1 or the 2 hours. And then the time to TPA, how much time is that? Randomization to TPA?
Start
6 minutes.
Yes.
And the start of TPA to thrombectomy 16 minutes. So this applies to a situation where within 2 hours of having a stroke or 3 hours of anybody declaring you are in the hospital, you have fulfilled inclusion, exclusion, you have signed the consent and you have joined the study. So clearly they have in that Chinese place a very good stroke network. Like we have 108. You can call, anybody can call 108. I think within half an hour somebody will actually land up in your house and then take you to hospital. But that doesn't mean that you'll have thrombectomy within the next few minutes. So many of these places, the ambulance people are trained to recognize stroke. So that when they go to the house to pick up the patient, they will tell the emergency department, there's a stroke patient coming. And then they will prepare the MRI room and then the stroke neurologist is ready. As soon as they see the MRI, let us go for thrombectomy and thrombolysis immediately. So that is, I think, otherwise it's impossible to imagine in India that within 2 hours of anybody in Vellore district, they will come to CFC, have an MRI. See, it's not only before randomization should have MRI to know which artery is blocked, whether you have hemorrhage, whether inclusion, exclusion. So all that has to be that much time. So in that situation, let us say that somebody in Vellore district has a stroke and they take him to a hospital with no neurologist. What will happen?
Then
they will refer to another hospital with neurologist. Or the doctor will just give some aspirin and keep quiet. So they must have had a up and spoke model or something where everybody in that district knows that if you come with a stroke, even the ambulance guys know, oh, stroke means I should not take to this hospital where there's no neurologist or they don't have stroke care. Or I can go to a hospital where they will quickly do a CT and say, oh, it's a major hemorrhage, it won't fulfill the study, let us manage here only. So they would have had a pre-existing model in place. For MI in Tamil Nadu, there's a new Tamil Nadu government has got this model. Anybody with MI goes to any GP primary healthcare center, there's a network. You go there, you must be referred to this hospital, immediate angioplasty or thrombolysis will be done. So our head Tamil Nadu government MI management is really good in that sense. Because they have that model ready. So we can do an RCT in Tamil Nadu because our model is already, data is already available. So compared to that, I don't know where in India we have that model. Maybe it's in Tier 1, Chennai, Bangalore, the metros. I don't know whether in Kerala they have that. Their health system is also good. Whether in some big cities they'll have. If anybody has stroke, these are the 9 hospitals, you just land up to the closest one. Because time is made. So 3 minutes time brain dies now. Cells keep dying in 3 minutes time. So that is the other question to be. Okay, go back.
Yeah, so the reason I was putting that yesterday was I was thinking that they are presented within the window period to a tertiary care center actually here. So I was thinking that maybe their population
but even if somebody comes within 2 hours to our hospital, within that 2 hours an immediate MRI should be done, an immediate decision should be taken, and come on, the thrombolysis and thrombectomy should have been done. Okay.
So that was
Okay.
and so are there limitations on the study that would affect your decision? Actually, this is the standard of care right now. That
So limitation of the study.
So there was nothing.
Yeah, but you said randomization was a little bit iffy.
Yes.
The baseline, there was some difference.
Some difference.
So here you should put, yeah, there was some baseline characteristic difference which make us a bit worried. It was open label, so there might have been some co-intervention in the arm which might have affected the study. Okay.
Yes, sir. So would it provide greater value to people than existing interventions? Yes. Ideally, if this is achievable, it would provide greater
So
value.
what's the extra cost of thrombectomy plus thrombolysis versus thrombectomy alone?
Check that, sir.
That's only the cost of thrombolysis alone, no?
Uh,
Both arms are getting thrombectomy.
Yes, sir.
One arm is getting thrombolysis
Yes,
as
sir.
well. What is the cost of tenecteplase? Anybody knows? Roughly? 10,000? 30,000. Tenecteplase injection 0.25 per kg is 30K. And then number needed to treat was
11.
so number needed to treat 11. Each person will cost
30.
one single injection of 30,000. So 30,000 into 11 is 3,30,000. So if you spend 3,30,000, you can get one patient with a functional outcome better. Number needed to harm is
55.
for a major bleed. So if you treat 55 patients, how many patients will benefit?
Benefits.
Number needed to treat is 11.
Yes.
With
So
11 patients, one will get better. If you treat 55 patients, that's the way to express it. If you treat 55 patients, one will have a significant intracerebral bleed
and 5.
5 will have a good outcome. Some people will put this as a ratio. 5:1. 5 better versus 1 bad. That is not the win ratio, but that is some people express the risk and benefit like that. Okay.
So overall, coming back to our case, the ideal management would be, if feasible, to proceed with thrombolysis and endovascular intervention, as per what we found. The current standard of care recommended is also endovascular intervention plus thrombolysis. So
But it comes at a cost.
Yes.
3 lakhs rupees
for
for one patient out of 5. So a patient asks you, what will you say? The cost to a patient is?
It's more than 3 lakhs, sir, because
The cost to one patient is how much?
they have to pay for the thrombectomy plus.
No, everybody is paying thrombectomy. Everybody has thrombectomy.
Cost to one patient is 3 lakhs.
No, if you treat
NNT
is 11.
Yes.
You treat 11 patients, 3 lakhs. But one patient has to pay 30,000 extra plus, I suppose, some IV line and some time of the doctor injecting. It's only a bolus injection.
Yes.
That's not much. But if you have the patient in the emergency department, if I treat 11 patients like you, one will get better. If the first patient is the one, we cannot predict which are the 11. You may treat 11 and nobody may get better. Between 22 patients, then it's only 2 or 3. So it's this number you can't be able to say you're the first one to get better. Okay.
So that is one.
Okay, let's give Dr. Vineeth's hand. Where's the win ratio data?
They've actually put it at the bottom. So they looked at the median, for example, median NIHS score they've reported as win ratio. NIHS score at 5 to 7 days they've reported as win ratios. So those are the ones that they're looking at.
Did they have an addendum with a picture of the win ratio? In the annex, did they have a picture of win ratios? No.
They've had a Kaplan-Meier curve for both, but win ratio, I guess.
Win ratio, they didn't have a picture. Sometimes the picture will explain that better. Just remember, one nice thing they have done. There's an article in NEJ, multiple outcome testing for the statistician and for the doctor. We'll discuss that one day. So they have got so many outcomes now. But the p-value of 0.05 is meant for a single test, the first primary outcome. How many secondary outcomes they have? So many secondary outcomes. So that's why in any chain they have said you should not report p-values for other than the primary outcome. Some other people say that no, there are so many statistical techniques to adjust for multiple testing. The easiest one is Bonferroni correction. So how many secondary outcomes are there? Including safety outcomes.
15.
So you take the 0.05 and divide it by 15. How much is that? We do maths. We don't have a smart calculator to do that. 0.05 by 15. 0.033. So the simple bond felony is if any one, that means you're distributing that 0.05 alpha across all 15 outcomes. So if any one of them is less than 0.03, say, but it's a very strict sort of way of doing it. Then there's a weighted bond felony. No, we take 0.02 for this, 0.01, you can do it. But so that's why NEJR is very strict. No. You just give the p value only for the unadjusted hazard ratio with the primary outcome. That's the correct way you should always present analysis. You can do adjusted for baseline, that becomes a secondary analysis. And they don't give you the p values for any secondary outcome, but they're giving you odds ratio or relative risk with confidence interval. So you can interpret if any confidence interval crosses 1, oh, that's not significant. But always secondary outcomes are taken with a pinch of salt. Because they are not, the study design itself, they are saying baseline characteristic was not equal because sample size was smaller. Relatively small, 270 is not a small number. Then you can't say, no, I'll do multiple secondary outcome testing. That is just hypothesis generation. The secondary outcomes are useful because if they also say the same thing, if all secondary outcomes are saying that the tenecteplase plus thrombectomy is better, it adds to your story. Yes, even the secondary outcomes are saying the same. If they say a different thing, then you're a bit worried. Half the story go one way, half the story go other way. That's the worry. Although that's very good. Any questions? Any question?
In allocation consignment, you had mentioned that allocation was the LCM.
Yes.
The randomization we chose was block randomization.
Yes.
With the fixed block of only 4. So in that case, would allocation have become predictable? Would that have contributed to the baseline differences?
Now that's an important point. If you know that there are 4, there is a block of 4, and we know that the first 2 patients got thrombectomy alone, then there's no doubt what the next 2 are going to get, because the block of 4, 2 have to get one and 2 have to get the other. So that's an important point. Yeah.
So if we say that there is question on randomization, it was open label.
Yes.
And you had this one loss to follow up, and your worst case scenario is not showing a significant difference. Would you still recommend that a combination treatment would be better than only endovascular intervention?
Yes, based on this study, no, sir. But overall, the evidence we have is pointing to. Based on this study alone, no, sir. So the interesting thing I found about the study was they were actually comparing standard of care to a very less, different things. So this was what actually this thing. So plus thrombolysis plus endovascular was upgraded, but this opposite arm was never compared actually initially. So that was one unique thing about the study. That they were looking at what if you remove the thrombolysis component, then it will be better.
Any questions from the virtual audience, please?